welcome to the First Fill. I'm Dan Zlott, and I serve as the Senior Vice President of Education and Business Development at APhA. As we continue our discussion of medication safety this month, let's take a closer look at community-acquired pneumonia. Inappropriate diagnosis of pneumonia can result in unnecessary antibiotic treatment, along with downstream sequelae, including antibiotic-related events, increasing levels of antimicrobial resistance, and increased costs to the healthcare system. Now, in 2022, new metrics for quantifying inappropriately diagnosed community-acquired pneumonia, or CAP, were established and have been endorsed by the National Quality Forum. According to this metric, inappropriate diagnosis of CAP is defined as any antibiotic treatment of CAP in a patient with less than 2 signs or symptoms of CAP, or who lacks radiographic findings consistent with pneumonia. Using this metric, a retrospective cohort study was conducted in the Michigan Hospital Medicine Safety Consortium. This retrospective study assessed data from 48 hospitals within the consortium from the period of July 1, 2017 to March 31, 2020. Inclusion criteria for this study included patients who were admitted to general care in the hospital, patients who were diagnosed with a discharge diagnostic code for pneumonia, and patients who received antibiotics on day 1 or 2 of hospitalization. Patients were excluded if they were treated for an additional infection unrelated to pneumonia, if they were severely immunocompromised, if they were pregnant, if they were admitted to the hospital for comfort measures, if they received care in an ICU, if they were placed on a ventilator, or if they left against medical advice. Other exclusion criteria included patients who were admitted to hospitals with fewer than 10 qualifying patients, patients who had unknown or missing antibiotic treatment data, or patients who received more than 14 days of antibiotics. Lastly, patients who had a history of COPD exacerbation treated with azithromycin or doxycycline alone were also excluded. Now, over the course of the study, 17,920 patients were treated for pneumonia across 48 hospitals in Michigan. 2,079 patients, or 12%, met the criteria for inappropriate diagnosis. Also of note, at 30 of 48 hospitals included in the study, 10% or more of patients diagnosed with CAP were diagnosed incorrectly according to the metrics I mentioned earlier. That's a surprisingly high percentage of inappropriate CAP diagnoses. Now, in addition to that, there were some interesting findings coming out of the study. Patients who were inappropriately diagnosed with CAP were more likely to be older, and by older we mean greater than or equal to 75 years old. They were likely to present with altered mental status, to have decreased mobility, or to have had a prior inpatient hospitalization within the prior 90 days. So what were the impacts of inappropriate CAP diagnoses? First, patients who were inappropriately diagnosed with CAP were more likely to be discharged to a skilled nursing facility. Second, patients inappropriately diagnosed with CAP received a median of 7 days of antibiotic therapy, 4 of which occurred as inpatient therapy. So although the authors don't state this, there were likely some increased costs as well as inpatient bed utilization associated with an inappropriate CAP diagnosis. Third, 87.6% of inappropriately diagnosed patients, in other words, 1,821 of 2,079 patients, received a full course of antibiotics instead of a brief course. Not surprisingly, there was a statistically significant difference in antibiotic-associated adverse events between patients who received a full course of antibiotic therapy and those who received a brief course, with 2.1% of patients who received a full course experiencing an antibiotic-associated adverse event versus only 0.4% in the brief course group. The p-value for that was 0.03, meeting the criteria for statistical significance. All right, so what should we take away from this? What can pharmacists do? Well, one of the best things is to establish a process for reviewing antibiotic therapy for presumptive community-acquired pneumonia 48 to 72 hours after the initiation of antibiotic therapy. If there aren't either signs or symptoms of CAP or radiologic finding consistent with pneumonia, this can be a great time to contact the prescriber to consider antibiotic cessation. That will do it for this episode of The First Fill. Thank you, as always, for listening and subscribing. Be sure to stop by APHA's Learning Library if you'd like to earn CE credit for this episode of The First Fill. And be sure to check out previous episodes for more on the latest in pharmacy.